Second-line treatment in metastatic colorectal cancer is a complex, let's say, endeavor. We do know first-line treatment have improved, first-line treatment have made treatment more efficacious. However, first-line treatment are somehow stuck in their efficacy as progression-free survival in first-line is about 12 months. So we have seen that patients live longer and longer, so this is also a result of second and further-line treatment. If we look to second-line treatment, and specifically the question which second-line treatment should be given after which first-line treatment, we have to first acknowledge that we do not have really good evidence to show which sequence is the best, because to date we do not have any sequential treatment trials. We do not have a trial which starts at first line and then ends at second line. So the evidence we grab comes either from second-line trials, where it is looked what happened in first line, or of those few first-line trials which also followed patients to second line. Extrapolating the evidence from this is one algorithm which seems to make sense, because there we do have some proven evidence, which is the sequence of anti-VEGF treatment, meaning first-line treatment with bevacizumab, and then having a second-line treatment also with bevacizumab, because we have at least two trials which have proven this, the Italian BEBIP trial and the Pan-European TML trial, where this sequence anti-VEGF bevacizumab followed by second-line bevacizumab provides in superior overall survival compared to second-line chemotherapy alone. We have also two other molecules which have proven efficacy in second-line, anti-VEGF compounds, aflibercept and ramucirumab, and both following either no bevacizumab pretreatment or following bevacizumab pretreatment have yielded better overall survival. So the anti-VEGF versus anti-VEGF sequence is clear. A bit of questionable is whether we should use for us wild-type patients anti-VEGF receptor antibodies in second line. I like to use anti-VEGF receptor antibodies in first line. However, if they are not used in first line, the question is, do they have to be used in second line, or can we follow the anti-VEGF and anti-VEGF and then anti-EGFR pathway, so meaning have three treatment lines being defined? And the data coming from three smaller randomized phase trials for me stress that this is a good strategy. So despite that we have very high response rates in second line with anti-EGFRs, and that we have some trend towards improved overall survival in a single trial, the majority of trials says we can use them in second line, if not used in first, but we can also use them in third line then. And having said this, I come to the beginning point. We need some more data from randomized trials proving sequences. We do have to learn more about sequences. There are two trials in Europe ongoing, one in France, one global trial, and those will show which sequence, starting with anti-EGFR or anti-VEGF and then following also the sequential and corresponding monoclonal antibody, will finally result in better overall survival.